Sir, please start. Thank you.
So a very good evening to everyone. Eleven-year-old male child, fifth birth by order, born out of third degree consanguineous marriage
Sir, voice is not there. Sir, you are not audible.
Yeah, can you hear us?
Yes, sir. You are audible. You are
Yes,
audible.
yes, Rajesh. Yes, Rajesh.
And you can see the slides also, right?
Yes, sir.
Yes,
Slides are
yes.
visible and full screen also.
So, 11-year-old male child, fifth by order, born out of third degree consanguineous marriage, Hindu by religion, from Mumbai, informant being mother, was brought with chief complaints of difficulty in getting up from sitting position and inability to walk since 7 years. History of presenting illness. Child was apparently all right 7 years ago when mother first got a call from school to let her know that child had fallen during assembly. After mother noticed frequent falls, inability to run, difficulty in climbing stairs, and difficulty in getting up from sitting position. The child started using his hands to push against his thighs to stand. Progressive worsening was seen, requiring assistance for daily activities. Gradually, the child developed difficulty in combing his hair but was able to eat with his hands. The weakness was bilateral, symmetrical, predominantly affecting the proximal muscles. There was no history of rash anywhere on the body before or after onset of disease, no history of fever, cough, cold before or at the time of onset of disease, no history of backache, no history of any sensory disturbance like tingling, numbness, or paresthesias, no history of dyspnea or palpitations, no history of any visual disturbances. Past history. There is history of multiple admissions in the past for recurrent respiratory infections. Birth and ANC, full-term normal vaginal delivery at 38 weeks of gestational age. Baby had cried immediately after birth. Birth weight was more than 2.5 kg. No history of NICU stay or jaundice. Pregnancy was uneventful as recalled by the mother. No history of decreased fetal movements. Developmental history, all the milestones till the age of 4 were achieved, followed by regression. Immunization is up to date for age. Family history, there is history of third degree consanguineous marriage and child has 4 sisters younger to him. Dietary history, the child consumes a mixed diet, 25 grams of protein and 1500 kilocalories. There is a deficit of 9 grams of protein and 300 kilocalories. Socioeconomic status is lower by modified Kupuswamy scale.
You come wait here. We'll just move that here. Meanwhile, the first complaint, come ahead, come ahead. The first complaint is 11-year-old child and 7 years back. So that means when this child was 4-year-old, this child fell in the school assembly, right? So your thoughts on that, start speaking. Then meanwhile, we'll just shift the laptop. When anyone start speaking, any thoughts?
Would have be attacked and fallen in school.
Excellent, very good. So to start off, you start thinking whether it could be syncope. Now, how will you confirm this? And start thinking about everything, about the age, about the circumstances. So first question is, would a 4-year-old get syncope? So usually syncope is seen at what age?
So yeah, more elder children.
So little elder children, so there's no hard and fast rule that till this age syncope can't happen, but typically it is seen in older children. Now, suppose this is very common, forget this case. You'll get this story. So in an older child, fall in assembly is 100 out of 100 syncope. But how will you confirm this? What else will you ask on history? Because you are not there at that time.
Blackout of vision before.
So blackout of vision. So you'll have to ask the child because nobody else will know. So you'll have to ask the child himself or herself, did you see any black before you collapsed? What else?
Had any food in the morning before?
Looking for triggers. So whether he skipped his breakfast, anything. What else? Heat. What else? What are the few things which will confirm that this was syncope, which you will ask the patient and you will ask onlookers?
Any abnormal movements and if the child lost consciousness post.
Very good. So you have to differentiate between syncope and seizure. So now tell us what are the different things. Can you lose consciousness in a syncope? Yes. So now how will you differentiate? Good, very good. You brought up a very important point.
Ask for any abnormal movements and
So finish the consciousness first. Anybody
Think usually triggers will be there
will come to that. Finish consciousness.
post-ictal phase.
Clarify that answer.
Syncope, I think the child will fall with the help of some support. Seizure.
Okay. So syncope also may seem unresponsive for a few seconds, but it's very short. Whereas in a seizure, that post-ictal phase can be longer, right? Okay. Then you said stimuli, triggers. So what are the triggers common?
Syncope usually the triggers will be fasting. Will be there.
Okay. Fasting. Okay. It's one of the triggers. Commoner trigger.
Standing.
Prolonged standing. Okay. In a hot atmosphere, stuffy, all that. Something more. Okay. Vasovagal is the mechanism, right? Why does it happen? Which is all part of the mechanism. Vasovagal, hypotension.
Sudden change in posture.
Pain is a very important stimulus. Then a unpleasant sight. So typically when you vaccinate a teenager in your clinic, when you start practice, the pain of the injection and they'll collapse, or the sight of that little blood and they'll collapse, right? So these are all the triggers. So in this child, you thought of syncope, but the age of 4 years is very odd. So you'll have to ask details that exactly what happened, why this child fell down, right? Okay.
I think when the problem starts at 4 years and looks like that there could be some neurological disease, the first thing is tell us the earlier milestones. For all that you know, this child could have had a delayed motor milestones, and that would put onset of a disease much earlier. So the presentation was at 4 years. And I think that is important. Now, in a syncope, it would have been absolutely normal. So every time we have emphasized this point that stories should start with how well he was prior to the first symptom. And in this child, you could have asked many more. For example, if you would have said, well, he started holding head and sitting, etc., reasonably time, but his standing was delayed. Okay. So if that was the story, would you think that is going to be progressive? I'll come back again. At 8 months, he was sitting very well without support, and they waited for him to stand at least at 1 year. But even 14 months, he had just hardly started sitting with support. Now, this could have happened with this child. Okay. Would you have thought at that time that this is going to be a progressive disease? Or it could have been some disease that could be easily taken care of? I'll give you another clue. I'll give you, yeah.
Disease which could have been taken care of. Hypothyroidism with such presentation.
Hypothyroidism congenital would have started even presenting early and not only motor delay, much more cognitive delay, constipation, etc. So tell me which disease occurs commonly between 6 and 12 months?
Spinal muscular atrophy.
Simple disease which happens.
I'll add one more, nutritional deficiency.
Rickets.
And typical vitamin D deficiency on a well breastfed baby for 6-8 months, complementary feeds, growing very fast, would land up with certainly some weakness, even many times even a seizure, which was hypocalcemic. So you could have asked about previous milestones, you could have asked about history right in birth, how well he was growing, etc.
4 years of age, he was doing very
No,
well.
mother says this, but the doctor must confirm. You many times said, no, history reliable from the mother. Then I will ask you, how did you confirm reliability? For example, I'm sure this child, if you would ask many more details, they would have said there was some delay early. Then you would have asked, what was the gait like? Okay. Was the gait abnormal? Now, when you ask such symptoms to the mother has noticed it, but she has not understood the importance of it. So she doesn't report to you. Moment you would have asked, how was his gait? He said, he was almost like this, lordotic gait. Because I'm seeing the diagnosis very clearly here. Therefore, I think that is important. So you would know onset of the disease was very early, right? Then do you think it being a congenital disorder, should it not have presented at birth only? Why is he waiting for our discussion of towards a year delay, etc.? First year, no delay. There is a disease. Any thought on that? So proximal muscle involvement, right? When do you start using them? That is the time it is, right?
So, few things that we learned from the discussion so far, at when one was that fall and syncope and all that we discussed. But basically, when you have a developmental delay or any such issue, and you have a pure motor problem, so start thinking right from the first step. Is it pure motor or is it global? Because your hypothyroid will come in when it is global, right? So you start branching out in your mind right away. So when it is a pure motor, it is a neurological peripheral nervous system problem, not even central, not even brain. Okay, peripheral nerve. That's a pure motor whenever you get that history. So that is one learning point that we have learned. And second, what sir pointed out, normal till sitting and then suddenly standing delayed. Think of a nutritional disease like rickets. Okay, so that is selective. Now here your
He said that by about a year the story started. Do you think it could be a congenital dislocation of the hip? That's another thing that is often missed. And then when he starts standing, sitting, parents notice some abnormality. Any thought on that?
developmental dysplasia of the hip. That's the current name of this. How does it present clinically? How will the parents come to us? So limb length discrepancy is something which we will pick up, right? So how will the parents come to us?
If the child is not able to flex the limbs, lower limb.
So you think there is a weakness in one limb because of the dysplasia? So like you rightly said, take it further, think. When will be a limb length discrepancy in a unilateral or bilateral? Unilateral, very good. Now, if there is a limb length discrepancy and the patient is walking, what will happen? Limb length discrepancy. One leg is big, one leg is small. What will happen? So, what will be the walk like? Limp. There'll be a limp or a drag or whatever. So, there'll be a unusual walk. So, it is not that a DDH child cannot walk, but the style of walking will be different. So, one leg, it will be a limb. Okay, more weight on one side or something. Both legs, waddling gait, right? So that is what you have to take the history, right? And then when you examine, you will get a limb length discrepancy or any other signs. So that was what sir had brought out. So in this child, you said one was that fall, and then mother noticed frequent falls, right? So again, we are learning from a broad to narrow. As sir said, once you are a little practiced, the diagnosis in this child is very obvious. So what are the other causes of frequent falls? How will you think when you get a child with frequent falls? Could be ataxia also, very good. If you heard the history, something in this history fits in with ataxia. Okay, what are the causes of ataxia? 1, 2, 3, 4, whatever.
Cerebellar sensory.
Ah.
Cerebellar attack.
Cerebellar sensor.
To that cause, then I'll tell you what was there in this history. Okay, I'll give you the clue other way around. This child was admitted because he couldn't walk. Why was he admitted?
Or respiratory infection.
Which ataxia is linked to respiratory infections?
Cerebellitis. Varicella.
Ataxia telangiectasia.
Very good. So ataxia telangiectasia is associated with IgA deficiency and recurrent respiratory infections. Because this child is not ataxia, but later you said recurrent respiratory infections. So coming back to frequent falls, one is ataxia. What else? We just now said developmental dysplasia of the hip. Unequal limbs will have frequent falls, right? Then, so think logically. Why should a child fall again and again? What could be wrong with the legs, motor system? So power could be a problem. Then tone could be a problem. So you could have one limb hypertonia. When do you have one? Again, asymmetry is what will make the child fall. So what will make one limb hypertonic? Excellent spinal lesion coming up slowly, right? So tone. Then coordination. You already said ataxia. Then if the foot is dropping, so peripheral neuropathy. So again, that child will tumble and fall, right? Muscles. So typically in DMD, they fall because of muscular imbalance between the front and the back muscles, right? So this is all causes of frequent falls in the lower limb. Then you go beyond the lower limb. Why could you fall outside of the lower limb? Very good. Vestibular problems. Then anything else? Excellent. Vision. So your vision may be affected, right? So keep thinking like this, that frequent falls can be so many things. It is not just your motor problem, right? Okay. So this was frequent falls here. Then, so you have to again get into the details, that one fall in the assembly and then frequent falls. Could all these be seizures? That one fall in the assembly was a seizure, and these frequent falls are also seizures. Could they be seizures? So can you have seizures which last for like just that few seconds? With seizures? Absence seizures, yes. But what happens in absence seizures? What is the hallmark of absence seizures?
Muscle tone will.
Daydreaming.
Daydreaming is the way they appear, but something important that talking of falls. So in connection with falls, I am asking.
Tone will be.
Epilepsy.
So myoclonus will lead to falls. Typically your salam fits of SSP, they will lead to falls. Whereas absence seizures don't lead to change in posture. So that is why even sitting in school, the child looks like as if he or she is daydreaming. But when sitting, the child doesn't drop like this. Child doesn't lose posture. So that's a peculiarity of absence seizures, right? Okay. So inability to run, and then comes difficulty in climbing stairs and difficulty in getting up from sitting position. So this part of the history, the earlier part, you have to figure out from all this, what is your problem, where is the anatomy. So you'll ask for power. How will you ask for power? Whether the power is normal or abnormal. Can the child kick? Can the child otherwise move legs in sleeping position? Everything is normal. That means there's no problem with the power as such, right? So you'll come down to the muscles based on all this history. And then your difficulty in climbing tells you what? Specifically, proximal muscles. So one small correction, that in your history when you recite, you don't say that the mother said that proximal muscles are involved. Mother doesn't know. So your analysis, when you give the summary, you say that this history is suggestive of more of proximal muscle involvement because there is a difficulty in climbing, right? Okay. Okay, and then you said that upper limb is also getting involved. The other thing you have to give is you have to give a time range. So all this happened over how long? Like it started 7 years back. So you have to just qualify it that slowly, slowly over next 2, 3 years or next 5 years or whatever, all this happened, right? Okay. Now, just for learning sake, come and tell us all your no history and tell us why you asked it. We are just learning. We are very happy that you took the lead to present today. Come this side only. Stand here so that it's easy, huh? And yeah, just pick up one by one and tell us why you asked that.
History of rash, dermatomyositis, and polymyositis.
Okay. Okay. So polymyositis term is almost now not used. Dermatomyositis, yes. It will be, so this is a very long story, 7 years ka story, right? So it's probably a bit too long, but still, okay, fine. Then
No history of fever, cough, uh, to rule out any viral infection precipitating this weakness.
correct. So now here again, this thing started 7 years back. And then it has been progressing all these 7 years, or it just progressed for a short time and then is static?
So from the age of 4 to 7, it progressed. After which the child was started with a medication which reduced the progress.
Sure. So what I'm trying to say is that a viral infection usually triggers a one-time event. Like a viral infection will trigger a ADEM or a GBS or a transverse myelitis, and there'll be a one-time problem, and after that, whatever recovery or no recovery. Whereas this is a slow problem from 4 to 7 years. This is not going to be triggered by a viral infection, right? Okay, go on.
The next is backache. To rule out radiculopathy means an AIDP going into CIDP.
Okay. So it's one more point you are trying to differentiate the anatomy, whether it's spinal cord or peripheral nervous system. So what are the other points which will favor spinal cord in the history, if you got it?
Sensory system involved.
Very good. Excellent. What else? Hyper. So spinal cord will give you both hyper and hypo, depends on where the lesion is. Okay. But typically muscle will not give you hyper. So you're looking for hyper. So if there is any hyper, then it will tell you, oh, is there a spinal cord involved? Okay. What else?
So if it's a motor neuron disease, there will be fasciculations.
Which are seen by the mother? No, they are seen by us, by doctors, right? So good. Motor neuron disease is a pure motor disease, which will not have any sensory problems. What is the equivalent of motor neuron disease in children? Motor neuron disease is typically an adult problem. One is polio. Second, very good, SMA. So SMA, there are different types. So the ones which come up later would be pure motor problem, right? Correct. Okay. Then
Sensory disturbances to rule out again. Final issue. No history of dyspnea and palpitations. That is in DMD. Usually you get cardiac involvement, cardiomyopathy. So that's why dyspnea and palpitations I have. And no history of visual disturbances because in Becker's dystrophy, most of the cases have visual disturbance.
okay, fine.
I think you have done very well, but we must have no history for a chronic progressive disorder. Okay. So that's why I said dermatomyositis, etc., are not chronic progressive. SMA, yes. So here you wanted to know that who is going to be progressive and not still a muscle disease. And that's where an SMA comes in. Ataxia may come in. Spinal compressions may come in. Okay, slowly getting worse. So your no history should be applied to the present situation. And you are right to ask all these, but some of them don't come as chronic progressive disorder. So take a note of that. You could have said before asking negative history, has this child's got a chronic progressive neurological disease? I want to be sure whether it is a loss of power. If it is so, whether it's SMA, then I'll ask whether it is symmetrical, whether it's worsening, as on this child. Then you could have said that it could be an ataxia as well, an ataxia of a long duration respiratory infection. So again, an IgA deficiency. It could be pain in the back and then slowly worsening sensory involvement, could be a spinal compression. It could be an intramedullary tumor, then you'll have a bladder bowel coming up. So you would have asked all such questions. See, the point is that in a short time in an examination, you want to tell the examiner that you have understood the whole story. We need not ask anything. At the end of all that, he said, I have no more questions. Right? Yeah, we are preparing you for that.
Okay, now, since you all are doing so well, you said that SMA is a motor problem. And this child has a muscle disease, we think. That's also a motor problem. So then on history, both are possible, no, in this child. We can't rule out SMA on this.
SMA will start a little early.
Yeah, but this is the latest variety of SMA, that 4 or 5. So, SMA is symmetrical, and this one is also symmetrical. No, you can still differentiate. I think all of you know the answer, but you think. History. Sorry. Frog-like posture is potonia. We all have a frog-like posture when we sleep. So that's not a problem. Think. You already said it just now, 10 minutes back. Fantastic. So proximal weakness, when it is prominent, it directly suggests muscle disease. Why? Proximal weakness more than distal is a sign of muscle disease. Why? Which muscles are bulkier? Proximal, simple, right? So that is your difference if you are cornered on history. In SMA, that will not be the story. that only climbing is difficult or whatever. There'll be a general weakness, right? And in nerve problems, which is worse? Distal are worse. Very good. Yeah. Okay. Sure. Go ahead. You stand here and present. Yeah.
So on general examination, the child is
First, tell us your history, provisional diagnosis on history, summary.
14-year-old male born out of third degree consanguineous marriage with gradually progressive bilateral symmetrical weakness of lower more than upper limbs with history of recurrent infections with no history of fever, rash, radicular backache and sensory system involvement is probably a case of muscular dystrophy, that is either Duchene or Becker's muscular dystrophy.
This is a boy or a girl? Boy. And
Consanguineous marriage, the
No.
child
other people in the family are involved, maternal uncles or.
no.
And we forgot to discuss why those recurrent infections.
So, due to the weakness of respiratory muscles, there can be aspirations as well as the bacteria can seed in because you are not able to take out secretions.
So is this child that bad? So if there are respiratory muscle involvement, then this child is bedridden.
Wheelchair bound.
So that you should have given in the history. Okay, no. In the history, you have to say.
Family history, you said autosomal dominant, autosomal recessive, or sex linked.
X-linked recessive.
Then what specific question you would ask? Family
Other-
history, but something
Yeah,
more
other
specific.
siblings, they are male or female.
But all are female. So
In maternal history,
Ah.
because it is inherited from the mother na X.
and mother is all right.
Mother is all right.
So what
Related
maternal
with
history?
mother, we will find someone in mother's relation to have the disease.
Maternal uncle,
Yeah.
mama. Okay.
Right?
Then, yeah. So you should have mentioned that the thing has progressed so much that now the child is wheelchair bound. So then those respiratory infections fit in. Okay. Okay. Fine. On examination.
General examination, the child is conscious, cooperative, and well oriented to time, place, and person. Is thin built, wheelchair bound, with a leaning posture. Vital parameters, child is afebrile, pulse rate is 86 per minute, which is normal in volume, character, and contour. There is no radio-radial or radio-femoral delay. Respiratory rate is 32 per minute. BP is 110 by 70 millimeters of mercury in right upper and left lower limb. Peripheral pulses well felt. Capillary refill time less than 3 seconds. No pallor, cyanosis, clubbing, icterus, lymphadenopathy, and edema. On anthropometry, the weight is 19 kgs, that is less than third centile. Height is 140 centimeters, that is between 25th to 50th centile. So weight is affected more than height. On head to toe examination, the positive findings were Gover's sign was present, Valley sign was present, there was lumbar lordosis and hypertrophy of the calf muscle.
So you could make the child stand. Okay. And you actually saw the Goer sign.
Yeah, his feet are moving properly. So when he tries to get up, his hands are also good. He eats by his own.
What is Valley sign?
Valley sign is you get a dip between the deltoid and infraspinatus muscle of scapula.
Okay.
Tongue is normal. No tongue hypertrophy.
And you said calf muscle hypertrophy. And what about deltoid and upper limbs?
Thin build.
Often tongue and pronators come up pretty early. Often tongue and pronators are affected early. So check on that, and maybe on examination you say they are not involved. Okay, because they are often
The
involved.
child has difficulty in speaking, so that must be due to tongue involvement. There was no gross or abnormality, but systemic examination, CNS, on appearance, there was no neurocutaneous lesion. Child is conscious, cooperative, well oriented to time, place, and person. GCS is 15 by 15. Memory is intact. There is slurring of speech. All cranial nerves were examined and were found to be within normal limits. Child was wheelchair bound with a leaning posture. The muscles of both upper and lower limbs were small and flabby, with proximal involvement being more than distal. There was hypotonia. Power of the muscles were in as follows: shoulder 2 by 5, elbow 2 by 5, wrist 4 by 5, hip 1 by 5, knee 2 by 5, and ankle 4 by 5. All superficial reflexes were well preserved. Deep reflexes were 2 plus at knee and elbow joint and 3 plus at wrist and ankle joint. There was no clonus, plantar reflex was present. Sensory system examination was within normal limits. Cerebellar signs could not be elicited. On respiratory examination, chest wall and respiratory movements are symmetrical. Trachea is central. Child has barrel-shaped chest with diameter. There is hyperresonant node on percussion in bilateral mammary and inframammary region. On auscultation, there is mild wheeze bilaterally in the same region. TVS S1, S2 is present with no murmur. Abdomen is soft and bowel sounds are present.
Okay. So few things now. See, what is grade 1 power? Flickering movement. And grade 2 power. Now, on one hand, we are describing a wheelchair bound child. Then on the other hand, we are talking of grade 1 and 2 power at different joints. It's difficult to examine that in a wheelchair bound child. So then, means I'm not saying that it's not possible, but then you will have to be ready with the answer that I lifted the child, I put him on the bed, then I checked and then I found power grade 2, right? Similarly, for the power that you gave, it is not possible for him to get up from the floor. So that you saw Gawar's sign, that is contradictory to him being wheelchair bound. So I'm just saying that keep all these things in mind. Unnecessarily in the exam, examiners will finger you for something which is, of no consequence, and our things will go bad, right? So it should all match with each other, the status of the child and what or Gawar's sign, but he's so weak that he can't get up. So that the examiner will accept, okay, after you give all your other findings, right?
Hyperresonant node,
Due to air trapping,
pneumothorax. Hyperresonant node.
his vital parameters are normal, so no pneumothorax.
So emphysema.
Yeah, air trapping.
Why
most probably.
emphysema?
Recurrent infections causing parenchymal damage.
So does that cause emphysema?
Secretions.
So that's unlikely. So you'll have to. Where did you get the hypernesmin? Which area? Both sides. So you'll have to just check it out again. It could be that he has lost a lot of muscle there. So he's very thin and emaciated. So that's why you are feeling that hyperresonant, right? Okay. So now,
Is
How
normal.
would you convince us that?
So I had asked him from where he is, where he lives, what does he do all day. He
But-
was able to answer all
And
the
his
questions.
behavior also.
His behavior is also decent.
Right.
Yes, because Duchene's doesn't have central nervous system involvement.
Should he have some CNS symptoms? Should such a child have some neurological symptoms mild enough? And then you have to say, I've looked for it, but it's not there.
Yes, because Duchene's doesn't have central nervous system involvement.
So does that cause emphysema?
Yes,
So dystrophin all. But of course, they're not measured, but these are scoring points. Okay. Right?
You have mild intellectual disability, so you'll have to, but that's difficult. Uh, Fine. So how will you put up your final diagnosis? Okay, first, we'll analyze our signs. Okay, just for exam's sake. So what are the signs you've got? Enumerate. What signs you've got? No. Wallace sign. Motor system examination. You've got power affection. 1. The power is weak or poor. Then 2. Tone is hypotonia. 3. Reflexes.
Decreased at knee joint, but present at ankle joint. Proximal
Okay.
affected more than distal.
Okay. But they're not lost. Reflexes are present. Right? So these three together mean a lower motor neuron or upper motor neuron?
Lower.
Very good. So saying that he came with this history, and on examination, we found a lower motor neuron disease. That's your first. Now, within lower motor neuron, you have to come down to say this is a muscle disease. So how do you know this is a muscle disease? So why is it not an anterior horn cell disease now?
Reflexes are preserved.
Excellent. So reflexes are preserved in anterior horn cell out. Okay, what else is out?
Symmetry.
No. Which other level of LMN is out if reflexes are preserved? You have 5 levels in LMN. No, anterior horn cell, nerve, then peripheral nerve, neuromuscular junction, and muscle. You have 5 levels. Out of these, 2 are ruled out if your reflexes are preserved. One you said was anterior horn cell. Second,
Neuron.
peripheral nerve. Fantastic. So that is out. So now you're left with muscle, NM junction, and nerve root. Now, which one is this?
So had it been NM junction, there would have been diurnal variation.
Very good. And it wouldn't have, or it may be diurnal variation. And which is the part which is most involved in NM junction? Eyes, face. Then you use adjectives, slowly, progressive, over years, and therefore this is a muscular dystrophy. Okay. And between Duchenne and Becker, which one? Why Duchenne? Good.
Early onset compared to Becker's, and other system involvement is not there.
Becker is more likely to be remaining ambulatory for quite a few years. No, this is already wheelchair bound. So to that extent, Duchenne is more likely. Very good. How will you prove the diagnosis?
What is the etiology?
On X chromosome at XP21 location, there is dystrophin gene, which is
I don't know whether it's an inflammation. Is it immunological disorder? What is the pathology in this? You get the point? Pathology. So what pathology? Why hypertrophy? I thought, is this myopathy or dystrophy? Myopathy, no? So then there should be atrophy. Where are you talking about hypertrophy and a muscle disease?
Is pseudo hypertrophy due to deposition of fat.
Fine. So now tell us what is the pathology? You're right.
Degeneration of the muscle. Because of lack of dystrophin, there is disintegration of the muscle.
What happens chronic progressive? What is Alzheimer's? What's the pathology?
There is deposition of
So anything that has been slowly progressive, functional derangement is due to degeneration. So this child has got a then you say etiology, possibly a genetically determined. Okay. But you said there's a myopathy, no?
So there's a difference between
Myopathy
myopathy and dystrophy.
What is the difference? And which is this one? And what is the difference? Tell us what is the difference that you know.
In myopathy and dystrophy.
So is this dystrophy progressive or not progressive?
Progressive.
And
And therefore, your answer is dystrophy is also myopathy. What is myopathy? Pathological muscle. This is also pathological muscle. But congenital myopathy typically is non-progressive, and then it will come with atrophy, etc. Then why is this hypertrophy?
Due to inflammation, fibrosis.
There is no inflammation. No, we said it's a degeneration. And you said lower motor neuron. Now every lower motor neuron will have an atrophy. Then why are you talking about hypertrophy?
The degenerate.
Very
okay, how will you prove the diagnosis? Hold close.
So 11-year-old male born out of third degree consanguineous marriage with bilaterally symmetrical progressive weakness in both upper and lower limbs with recurrent respiratory infections and failure to thrive, Gover's sign and Wallis sign present with hypertrophy of calf muscles, decreased power and preserved reflexes and no sensory involvement with barrel chest and hyperresonance is probably a case of inherited muscular dystrophy, that is Duchene's or Becker's with emphysema.
Don't bring in emphysema and don't bring in Becker's also. Okay, Duchene's. How will you prove the diagnosis? Investigations.
MLPA is the
Okay.
investigation of choice.
So you should give it in a little dilated answer. So you should say, we
Genetic.
will specifically look for the genetic diagnosis, and for that, the best procedure is MLPA. Okay. Any, would you like to do a EMG?
We can do so.
And so you can do everything. Tell me pros and cons. So is EMG good to do, bad to do? Is it diagnostic?
EMG is not diagnostic, but it will help us to it from SMA in late stages of SMA. The
Rule
later
out other cause.
right?
What about enzyme CPK?
Will be very elevated initially, then would settle down.
When will it settle down? When all the muscles degenerate. So that is extremely late. Okay. Now, what is the usefulness of this CPK in clinical practice? Response to treatment, I'm not
Again,
so
it
sure.
differentiates.
If you have that doubt, okay. What else? So what will be the mother's CPK? Very good. So carriers have a very high CPK, though they will not be symptomatic. So to identify carriers, it's a simple Of course, you want a genetic diagnosis, that's different, but CPK raised tells you that this person is a carrier. Okay, fine. Very good. So good for a regular feature. Okay, very good. Excellent. Come. एक
Good evening. Good evening, sir. I'm Dr. Karan Shah, second year resident at Sion Hospital. Today I will be presenting the short case. A 5-year-old male child, second by Asian, hailing from Banaras, came with inability to speak and weakness in the right upper and lower limb since one day. So the child was all right, after which he had a history of fall on ground while playing with the siblings, after which he was conscious but was not able to speak. Child was able to move both his upper and lower limbs. Child was brought to the hospital
Rajesh,
for
we can
inability
still,
to speak.
excuse me, we can still see the old presentation.
अच्छा, okay. Yes. Yes, sir.
Yes, now the new one is visible. Thank you.
Thank you.
So the child was apparently all right, after which he had a history of fall on the ground while playing with siblings, after which he was conscious but was not able to speak. The child was able to move both his upper limbs and lower limbs. The child was brought to the hospital with a complaint of inability to speak, but since he had a history of fall, he was taken to ortho in view of trauma and was sent home on oral medications. Child went to sleep after going home, and parents noticed that he was not able to move his right upper limb and lower limb after waking up. The child was brought back to the hospital, was admitted, CT brain was done. Further, child was transferred to our ward for further management. There was history of loss of urine sensation and urinary incontinence, history of deviation of angle of mouth to the left side. Child was able to understand what the parents were saying to him, but was unable to speak. Negative history. There was no history of loss of consciousness, headache, vomiting, seizures, similar complaint in the past, loose stools, fever, altered sensorium. There was no history of any blood transfusion or any cardiac illness in the past. ANC is uneventful. Birth history, full term, normal vaginal delivery. Birth weight of 3.4 kg. Baby cried immediately after birth. There was no history of any NICU stay. Developmentally, the child is appropriate for age. If child is immunized for this age.
So now, what are your thoughts on this? That he was playing with his siblings and he fell and then he couldn't speak. This is the story. So what are your thoughts on this? What must have happened? What could have happened?
Possibly their um, child playing and he uh, fell down and was not able to speak. It can be because of uh, uh, stroke, possibly.
Okay, very good. So it could be a stroke. If it is a stroke, then should there be a motor deficit along with it or no? There should be. So you've confirmed that at that moment he was fine.
Yes, sir.
So he could actually walk.
He actually after he gone, he walked and he himself walked with the parents. Then when he reached home, after that he slept, and
But till that time he couldn't speak.
he couldn't speak. There was no motor involvement, but he couldn't speak.
So typically I wanted to make you understand one more different point, that you get this history very commonly, that a child fell and then there was a neurological issue. Here it is sometimes difficult to differentiate what came first. So here in this child, you are 100% sure that he didn't have a motor deficit. But the other way around, somebody who develops a stroke and a hemiparesis falls because of the hemiparesis. And we think that he fell and then he developed hemiparesis. So this is often a problem in history where you try to differentiate what came first.
I think if the history is right, that it started with inability to speak, but he could walk at that time. And thereafter, a few hours later, parents came back again. So the point is that uh, you're right to say it started as a stroke. Now, why should a stroke worsen in its presentation? And therefore, I thought that this kind of a inability to speak should further be inquired. What does it mean really? First is he able to have a good receptive language? So he understands everything. Okay. If he did not understand what we were talking, then he would not answer. So first you confirm that his reception is fine. Then the motor system, what kind of attempt to talk results into an improper word or unclear word? For example, a child with a facial palsy is able to speak, but the person may not understand what he's speaking, or he may not be very clear in his speech. So when you say inability to speak, it's a motor system you're talking about. And motor system, could it be a tongue involved? Could it be a palate involved? Could it be the respiratory system involved? Or could it be the face involved? You could have started asking all these details, and therefore you would have known whether this is going to be. But a stroke is most likely. Then my next question is, if focal stroke comes up like this, then the worry is whether it is going to extend further. Now, what vascular illness could extend slowly? And that, to my mind, could be a thrombosis, which is kind of enlarging, blocking the vessel, and therefore they came back again. The point is that at that time you would have said he's heading for some trouble. We don't know what trouble, but I would have checked his palate, I would have checked his tongue, I would have checked his facial. And if all was normal, which was unlikely, then I would have picked up a neurological disorder coming up. Now, at that stage, then we would have thought it is better you stay here because something is yet to come up. And I think that is what we learn out of this. This is unusual, surely, because the parents note first the paresis and they even don't note the inability to speak. So here it has happened like that, which itself is unusual. But when we start analyzing, the point I'm making is the motor component of speech requires me to breathe well first, exhalation. Then I need to have a good palate movement, the tongue movement, and also the facial. So we would have started localizing the lesion.
Words, what would you call this inability to speak as in this child? Motor aphasia, right? So where is the problem? Broca's area. So this mechanism, this peripheral apparatus which sir talked of, is normal or abnormal? Is normal. understand, the child can decide what he wants to reply. So his cognition is also normal, but because of the Broca's area being involved, he cannot execute what he wants to reply, right? That is your motor aphasia. And what is sensory aphasia? How will it clinically appear?
He'll not be able to comprehend only what the other person is saying. He'll speak irrelevant.
Very good. So he'll speak irrelevant. So he'll speak something else only, right? Oh.
Broca's area situated.
नंबर है lateral surface, medial surface, front, back. So lateral surface, yeah.
So the point is, so why motor aphasia? Moment you say it's a motor, then you start wondering what other motor involvement he had. I imagine he could have had some mild. The attention was not able to speak, so possibly they could have carried him because he came suddenly
Yeah,
out
but
of
he's saying he walked.
walk
So
also.
that
So
is-
that was a bit unusual, but yes, I think at that stage we would have said it's a motor aphasia.
Fine. So after history, what is your provisional diagnosis?
Sir, 5-year-old, second by birth order, coming with right-sided upper limb, lower limb paralysis of stroke.
So hemiparesis. You
Hemiparesis.
say right hemiparesis with
With
motor
motor-
aphasia.
motor aphasia.
Specify with a facial.
Yes, sir.
Okay. With
But-
right. Yeah.
With-
Right facial.
Yes, sir. Upper human palsy.
Stroke.
Yes, sir.
Stroke due to means a vascular problem.
Most likely a ischemic
Correct.
problem.
But in ischemia, due to embolus, thrombosis, hemorrhage,
Sir, mostly because of thrombosis.
why? You're right, but you have to justify everything. So why?
Sir, emboli at this age slightly unusual.
No, don't say that age is unusual, but you're right. So what happens in
No.
an embolus?
So no cardiac.
Very good. So first is there's no history to suggest a source of the embolus.
Yes.
1. 2, what happens with an embolic stroke in terms of timeline? Sudden and full. So everything happens in one go.
Yes.
That didn't happen here. So that's why unlikely embolic.
Yes.
Why not hemorrhagic?
No loss of consciousness.
Very good.
No.
So hemorrhagic is a very catastrophic disease.
Yes.
So there'll be a seizure, there'll be loss of consciousness.
Yes.
All that didn't happen.
Yes.
And therefore, because this built up slowly over a few hours, mostly thrombotic.
Sir, on general examination, child is afebrile, heart rate of 108 per minute, respiratory rate of 24, SpO2 maintained at 100%, head to toe examination is normal. CNS examination, child is conscious, oriented to place and person, inability to speak. Child is currently in sleeping position with right upper limb extended at shoulder and elbow and right lower limb extended at knee and adducted at hip with spontaneous movement of left upper and lower limb. Girth is equal on both upper limb and lower limb. Tone is decreased in both the limbs, right more than left.
Decreased.
Decreased, sorry. So the power on the right side is 0/5, sir. And on the left side, it's more than 3/5.
5-year-old, you said.
Yes, sir. So power at hip, power at knee, and power at ankle is the same. Wow, it's right is 0/5 and left more than 3/5. So sensory touch present at both left and right side. pain present at both left and right side. So the other I could not examine because the child was not cooperative. So cranial nerves, cranial nerve 1 couldn't be examined. Cranial nerve 3, the child direct and indirect reflexes are present. Uh, 3, 3, 4, and 6, child is able to move his eyes in all directions. Corneal and conjunctival reflexes are present for fifth. Sir, for 7, there is left-sided deviation of angle of mouth and loss of the nasolabial fold on the left side. Child is able to localize the sound. Sir, and other nerves I couldn't examine because the child was not cooperative. My final impression of a 5-year-old child, 5-year-old male child with right-sided hemiplegia with upper motor nerve, facial nerve palsy with Broca's with motor aphasia.
Yeah. Only thing is, see, in exam, don't get confused about the facial. So which side loss of nasolabial fold will be there?
Opposite.
Usually same side as hemiplegia or opposite side? Same side. And which side ka facial is usually gone? So right hemiparesis with right upper motor neuron facial or left upper motor neuron? Left is crossed. So it has to be right.
Right.
So right upper motor neuron facial with right hemiparesis. Right side nasolabial fold is obliterated or weak. And the angle of the mouth is
Deviated to the
left
opposite
side.
side.
So all this you shouldn't get confused. Okay. Because sometimes it's all difficult and then you mix up everything and then that's where you will go down.
Yes.
Okay. So be clear on this. Yeah.
So
How will you investigate him?
Sir, so the child came to us yesterday. So first, the CT brain was done previously in the E ward. So CT brain was suggestive of narrowing of MCA segment, narrowing of.
How on CT we could make out?
Sorry,
Just a plain CT or
sir, SCT angio.
CT angio?
CT angio was suggestive of acute infarct in the left parietal region, and M1 segment of left MCA was likely narrowed because of thrombosis. So when the patient came to, then also DSA was done by neurosurgery, which shows chassis of anterior and anterior and middle cerebral artery circulation. So the child came to us. So from our side, we have sent bleeding profile with D-dimer because we want to start the child on low molecular weight heparin. We have already started the child on aspirin. We have also sent CBC with PS with retic with sickling because we are suspecting it sickle cell anemia can also be a cause. Um, Apart from that, we had also sent a lipid profile which came out to be normal. Um,
Yeah. Besides this, you usually look for homocysteine as a
yes, sir.
part of a hemiparesis
Workup. Yes, sir.
right? Oh.
2D echo has been done, sir. The 2D echo has come normal. Rest of the reports, the blood work, the CBC, the LFT, RFTs have come normal. Our plan is to wait for the D-dimer levels to come and start on enoxaparin, that is low molecular weight heparin. Right now, we are not planning to do any other neuroimaging as such. We will wait for the child response.
I think the only other condition that can come up like this is a mitochondrial disorder. And just keep in mind that, okay, certainly not a common at all, but therefore the question is, how are you sure it's not a mitochondrial disorder? Okay, after all, there is an infarction. Infarction doesn't tell you the cause of it. So it could be a metabolic disorder. So how would you convince me that this is not going to be any metabolic disorder, mitochondrial disorder? And therefore you would have said that this is likely to improve. And even after improvement, you will have to possibly tell them that this has a chance of recurrence. Now, typical mitochondrial disorder mailers have also lactic acidosis, but that's one point of it. So the question is, I always thought that these children recover pretty well, and therefore today evidence-based medicine needs to do carotid angiogram. But there is enough evidence to say this is that, and that has not told you the cause of all this. Therefore, you should say that CT angio may not tell me the cause, but at least confirm my clinical judgment that there is an infarction, so that you are sure. Because there are different types of examiners. Somebody would say that, why are you wasting money for CT scan, angio, or exposing to radiation? All such things would be given. So you say that this is what it is. But one possibility is the mitochondrial disorder, and that could relapse. Whereas a thrombotic profile is abnormal, that could also relapse. So I think that counseling will be important, that even if a child improves, keep in mind if suddenly something happens, please mention that this had happened in the earlier. Right?
So, sir, because of the hemiparesis, we knew that MCA is getting involved. But since AC, we now got to know that since ACA is involved, that's why the urinary and bowel incontinence. So that helped us initially.
Yeah, I forgot about the bowel. He had a bowel incontinence also.
Bladder incontinence
Yeah.
was very evident. He was not able to.
Okay. Fine, good. Any questions? Okay. Anything from the online audience? Any questions? Any comments?
I thought, can I say something, Rajesh?
Yeah. Tell me.
Yeah, I was just thinking whether DSA was very invasive and whether they should have done an MRA or any other MR testing before going for DSA.
Yeah, so that is, she's saying that could you have done a MR angiography instead of a DSA? So I don't know whether, that would have been good enough or no in this situation. I don't know that.
Also, that this DSA was done late night, and MR angio usually is neuroimaging is not happening that late. So
Okay.
neurosurgery decided maybe to take for DSA first.
Okay, fine.
Their advice was to do an MR, but they didn't.
Okay, so it was a logistic
Logistic,
difficulty.
no.
Okay.
I think the MR would be specifically required if you are considering something more than just an infarct. Otherwise, infarct, I think the CT scan, CT angio is the ideal thing. So here, I don't think you need an MR really. And MR would have required also the anesthesia. So CT scan should be good enough.
Yeah. Anything else, Anjali?
No, also I thought that the typical moya smoke puff is not seen. Otherwise, that was maybe that could be entertained.
Yeah, so like sir said, we'll have to follow up on this child. We don't know. This is the first episode. So we'll have to see what the future holds, right? Yeah. Anyone else? Anything else from online? Okay. Thank you. So we meet next Thursday again at 5 p.m. Okay. Thank you.
Thank you, Amdekars sir. Thank you, Rajesh, and thank you all those who presented. Thank you.
Thank you.